is Carlo Lazzaro Solero, and he's going to talk about cord tethering. The floor to you.
Buongiorno a tutti.
Good morning, everybody. We will show you the results of surgery on adults with Chiari malformation. And then later on, Dr. Valentini will talk about children, so we decided to split the presentation into two groups. This is Uncle Chiari. I say uncle because now we are very familiar with him. We have seen a couple of times. We've seen him a couple of times in these days. I referred to this large review of a very large number of cases on which we worked together. They propose a cervical decompression and occipital decompression surgery, and with the occipital surgery they go down to the second and third vertebra, which sounds a little too much to us because being too invasive in the spine might cause a kyphosis and instability. They say this can be accompanied with a shunt, which in our opinion, on the contrary, should be a sort of second choice. And they say this decompression offers favorable clinical results. They also say that an anterior approach could be adopted by removing the dents of the atlas, or the axis, but this sounds a little too exaggerated to us. And in the end, they talk about detethering of the lower marrow, and this is still controversial. I think that we still have to debate on that, and then later on during the day we will also face this problem. So let's now focus on our surgical technique. We propose a cranioscervical decompression with bilateral suboccipital craniectomy, C1 laminectomy, and that's where we stop. This could be associated to section of the atlanto-occipital ligament, a dural patch, cerebellar tonsil cauterization, or a cerebellar tonsils resection. And you'll see in our cases, this is our strategy. We tried for some years to do only the bone decompression without opening the dura, but we decided to abandon it, and we perform on all patients duroplasty. The discussion about the sectioning the phallum terminalis is still under discussion. This is our procedure, and this is how the surgery is performed. This is a bilateral suboccipital craniectomy, and then C1 laminectomy. The opening of the atlanto-occipital ligament, and therefore dural decompression, the opening of the dura, if possible without opening the arachnoid, and duroplastic. We do it longitudinally, almost always using a lyophilized dura. And then the exposure of cerebellar tonsils with cauterization, or the resection of cerebellar tonsils to make room. And here you see a case of phallum terminalis dissection. Here we say the Chiari, the syrinx, the opening, bone decompression, the duroplasty. Let us now see our patients. We have divided our patients. We have split them into groups because there are differences. Also because in the past, adult patients were only operated in case of severe deficiencies because it was hard to make the diagnosis. The MRI was not available, and so then the second group ranges from 2000 to 2008, in which we have operated patients with better neurological pictures. You see that the cases are very similar. All in all, we have 217 patients. We have more women, as you can see, and here you see the mean, the age range and the mean age. Let us take a look at symptoms. As to symptoms, there's no major difference between the first group and the second group, and we talked extensively about symptoms yesterday. Here you find the list. Let us now take a look at the neurological signs. And in this list we see that there are actually major differences between the two groups. Because, for instance, the cranial nerve deficit in the first group accounts for 51%, where it goes down to 8% in the second. The same applies to sensitive deficits, a little less in the case of motor deficits. In pyramidal signs, there are remarkable difference, and then ataxia and scoliosis. Here we don't see major differences. And then normal patients, as far as normal patients are concerned, we have more patients in the second group. As to syringomyelia, it was present in 94 versus 87% of the cases. The length of syringomyelia is defined by these figures below. Hydrocephalus, never been very frequent in our cases. However, in the first group, it is slightly more present, and in some of these patients we performed the shunt, the ventriculoperitoneal shunt. I'd like to show you a case of hydrocephalus. In this case, the third ventricular sternostomy might solve the problem posed by the Arnold-Chiari malformation. What have we done in these patients? So in all patients, we have done decompression, and craniectomy, and laminectomy. In all patients, we've done dural scoring. Dural patch was made performed in 94% of the first group and 96 in the second. Cauterization of cerebral cells was done in this percentage, and tonsil resection especially was performed in the second group in special cases. And this is an Arnold-Chiari with a small syrinx. You see the incision, the excision, the exposure of the brain stem C1 and C2, and the opening. We often use the high-speed drill because it's more handy to do to perform the suboccipital craniectomy. Here you see the exposure of the occipital and cervical dura. Here we open up the dura without opening the arachnoid. You can see the duroplasty that has to provide this decompression. Then suture, we always put fibrin to avoid CSF leakage. Complications. Here we have the list. There are not many. The major complication is CSF leaks. This is not a true fistula because it's not that we had to reoperate these patients because oftentimes CSF leak develops, but in the end doesn't need to be treated surgically. And then additional surgery. Some patients, especially in the first group, were reoperated to extend the bone, craniectomy, and the dural patch. Some of them were submitted to syringoperitoneal shunt. And in the first group, some patients underwent syringo subarachnoidal shunt. One case was treated for cervical instability. The follow-up is long because this is a very large series. And we have defined patients who have healed, improved, remained stable, or worsened. And actually, we had patients also that worsened over time or post-operatively as a result of the disease. As to the syrinx, we defined it as having disappeared or having shrinked a lot in 29% of the cases versus 31, and in then reduced or shrinked, and 44 versus 51, and then the rest is stable. Here you see these very large syrinx before surgery, and after surgery, you see that the syrinx has shrunk. Here you see the reduction of the syrinx and the space that has opened up behind the cerebellar tonsil. This is another case of the syrinx before, preoperatively and postoperatively. Another case, here you have the syrinx, and here you have the space, and this is the CSF flow assessment. Here we have a larger syrinx. Here we have the decompression, bone decompression, and reduction of the syrinx in the cranial and in the caudal portions. Another case, as you see, you enlarge, you extend the space behind the tonsils, and the CSF flow improves as a result of that. And the same is true here. This case, well, at first sight you may say nothing has happened, but you can see that from 2005 to 2008, you see that the syrinx is less tensed, and the CSF flow around tonsils has improved. And this was the volume of the syrinx, and here you see the volume after 4 years. This is a case of resection of the tonsil. Then Dr. Valentini will discuss it, but in adults, the untreated craniostenosis can lead to this crowding in the posterior fossa, and therefore this Arnold-Chiari syndrome. So you may immediately tell that this is an untreated craniostenosis, and also this lady has this untreated craniostenosis that then led to Arnold-Chiari with syringomyelia, and here you see the outcome after decompression. Let me show you this case, a 24-year-old girl that I operated for myelomeniingocele, who had major apneas and also cardiac and respiratory arrest, and was intubated and referred to us. And as you can see, we have this crowding of the tonsils with this syringomyelic cavity. We performed a decompression on this patient, a very large one with a very large patch of dural-plasty. Here you see fibrin glue, and also we see the removal of the occipital bone, and these apneas disappeared. I'd like to show you this case because this was an excessive destruction of the spine, might cause spinal kyphosis. And then, as a sort of provocation, I'd like to show you this case of this child who had this Arnold-Chiari with tonsil descent and shattered phylum terminalis, and therefore in this case we performed a joint combined surgery, performing two excisions, and then we did decompression. The decompression, the opening of the dura and the resection of the tonsils, as well as dural plasty. And simultaneously we exposed the dura, the filum terminalis, and we dissected the filum terminalis. Conclusions we can draw are that we believe that bilateral suboccipital craniectomy and laminectomy of C1 plus dural patch is the gold standard in patients with symptoms and in patients with syrinx. Craniovertebral decompression without dural patch, on our opinion, is not successful. Syringoperitoneal shunts should be considered as a second choice surgery. And then the resection of filum terminalis is still under debate. We will discuss that later. Do we want to have the discussion now, or do we want to have the presentation by Professor Valentini? Well, let's have the discussion. Is there any question from the floor? In the afternoon, I will show you a case which is very similar to that case of untreated craniostenosis you showed. My case is an 11-year-old child that had the same problem. He had a ventricular distension, as I could see in your case as well. In this child, before scheduling surgery, I preferred to but this is a typical clinical picture of Chiari, and however, I noticed an abnormality in the intracranial pressure, especially during sleep, and therefore I planned treatment with the family involving CSF shunt. And much to my surprise, we had a complete remission of all symptoms. And after 1 month, the MRI showed that the syrinx shrunk extensively, but there were all Chiari malformation signs left. And a very important sign is that you can't see the cisterna magna. So this is a sort of asymptomatic Chiari syndrome. What I'm asking is what treatment did you adopt for that patient, and was it enough? Well, in the second case, we perform traditional craniocervical decompression, and in the second case, we didn't do anything, if I remember correctly. He had a Chiari with no syrinx and no ventricular distension. In case of ventricular distension, we first treat the ventricular distension. It is rare to find these compensated forms of craniostenosis. More questions? One of the controversial points is the opening of the arachnoid. if possible, because if it's very changed, you open the arachnoid as well, but I actually don't care too much about that. I do it routinely, and I always do it because the arachnoidal probing doesn't cause any problem in my hands. And then you see also perforations of the Mackenzie. And so the outlet of the fourth ventricle did not work. And with this approach, you can open it. Yes, you're right. Sometimes you have a thickened arachnoid that should be opened so as to free up the tonsils. And on other occasions, if you find a clean field, you think you're more safe, and you can make a more tight plasty. But this is not the rule. Sometimes you have to do it to free up the tonsils. Your experience is very similar to ours. As to the opening of the arachnoid, I think it depends on the severity of the chiari malformation, because if it's moderate or mild, it's better not to touch it, whereas if the symptoms are severe, it's much better to open the arachnoid. I've seen that in the second group, you have an incidence of symptom-free cases, which is quite relevant. Since this is a problem, I would like to understand why you opt for surgery. Yesterday we talked about surgical indications, so when to perform surgery and how. In general, if in a child we have a symptom-free chiari, I reiterate that, a symptom-free chiari, but with syringomyelia, it is advisable to operate. In adults, things change because many other factors need to be considered. Because if we have true symptom-free adult patients, a slight tonsillar descent and a small syrinx, I keep this patient under observation and I see how the situation unfolds. There are some cases that, despite being symptom-free, have maybe a large syrinx, perhaps are not too old. It's advisable to schedule them for surgery, because the surgery might be beneficial in these cases. Should randomize them, should make a randomized trial. Oh yes, you're right. A short comment referring to what Dr. Gaidi said. We tended to adopt a different approach to children compared to adults. You said that once you do surgery, you suggest or you say that you have to open the dura as well. Perhaps this is not completely true for children, because one might be less invasive in the presence of small syringomyelic cavities, because all complications are associated with the opening of the dura. If the dura is not opened, you get fewer complications. And so all in all, of course, for adults things are different. Either you operate them or not, but children could be treated differently. So if you are careful in opening the dura, in the end you can obtain the same results with fewer risks. Well, let me reiterate that we had a neurosurgeon in our hospital, Professor Borghi. He decided to only perform bone decompression. Unfortunately, I don't have the elements to tell you and to explain you why we abandoned it, but we realized that the reduction of the syrinx was not as relevant as in those submitted to dural decompression as well. So in the end, we decided not to do it anymore. As to the opening of the fistula, it's true we had to reoperate a few, but not many, because in some cases we have this CSF cyst that doesn't require a reoperation. And in this case, I'm talking about adults. Feel free to add anything. Perhaps we can have the last question from Dr. Giussani. There's something that is unclear to me. As Professor Chiani said, in the second group, there are more symptom-free patients, but I've seen that you have 65% of patients with headache. I'd like a comment from you on this. Did you focus more on the presence of a headache? Well, headache after sports activities, we talked about that later. So in this case, it's better to perform surgery because you can solve the problem, especially in young adults. I'm not a surgeon, so maybe my question is out of place, but as to the hydrocephalus, Dr. Valentini said that the hydrocephalus needs to be treated first, but what is the evolution of the neurological symptoms in these patients treated for the hydrocephalus? Do we have an overall improvement, or what happens? Well, we have a few cases in which CSF flow treatment solves the problem of the syrinx, and on the